this module, I am going to discuss about inherited tubular disorders in children. Before looking at the individual disorders, let us see some common features of this group of disorders. We all know that the most important function of the renal tubule is in the concentration of the urine. So when the tubule is not functioning, this concentration of the urine will not occur, and this results in excess urine output from the kidney. This is what is called as polyuria. Please remember, an important definition of polyuria is daily urine output of more than 2 liters per meter square. This meter square refers to the body surface area. Okay, so polyuria is the main feature. Second important feature is, because of polyuria, there is also thirst excessively that results in excess drinking of water by the child. This is called as polydipsia. And a third important feature is failure to thrive. This is a condition wherein, due to the tubular problem, child is not able to gain weight and height. Okay, now remember that tubule is also an important place where there is reabsorption of nutrient like glucose, amino acids. So in a tubular disorder, there is impaired absorption of this nutrient, and that can contribute to failure to thrive. Okay, so these are the common features to all tubular disorders. Okay, now let us look at the name of the disorders. There are 3 important conditions which you should know. One is the Bartter syndrome, wherein the problem or the site of defect is in the ascending limb of loop of Henle. The next condition is Gitelman syndrome, where the site of the defect is in the DCT, which is distal convoluted tubule. And third condition is called as a Liddle syndrome, where the site of the defect is in the collecting duct. Now, as an overview, I would also want you to remember what is the actual defect in each of these conditions. In Bartter syndrome, there is a transporter called sodium potassium 2-chloride co-transporter. That is actually defective in Bartter syndrome. If you remember, this Bartter syndrome will have features closely resembling that of the diuretic furosemide, because furosemide acts by inhibiting this co-transporter. In Bartter syndrome, this In Bartter syndrome, this co-transporter by birth itself is defective. So this mimics the action of loop diuretic, that is furosemide or furosemide. Okay, right. In Gitelman syndrome, the defect is in the sodium chloride co-transporter, which actually mimics the action of thiazide diuretics. Thiazide diuretic actually inhibit the sodium chloride co-transporter, whereas in Gitelman syndrome, by birth itself, that transporter is defective. Third important is Liddle syndrome. In Liddle syndrome, the defect is gain of function mutation in the gene which codes for a channel called ENAC, which is epithelial sodium channel. Whenever there is a gain of function mutation, remember that there is an increased activity of this channel. Okay, this is very important to note, because in the previous 2 scenarios of Bartter and Gitelman, I said there is no activity of the co-transporter. But in Liddle syndrome, there is an increased activity of the epithelial sodium channel. That's a basic difference which you need to know about. Okay, and one more starting point for this disorders is Bartter syndrome and Gitelman syndrome is inherited in an autosomal recessive manner, whereas Liddle syndrome is usually inherited in an autosomal dominant manner. This is a brief overview of the three important disorders under inherited tubular disorders. Now I am going to explain all these disorders in detail.
Let me start with the first one, that is Bartter syndrome. It is an autosomal recessive disorder with onset in infancy, that is less than 1 year, which is characterized by loss of function of three important genes coding for some transporters. One gene is here, this is number 1. What is that? It is sodium potassium chloride co-transporter. That is the first transporter which is defective due to that defective gene. Okay, right. Second is this one. It is called as ROMK channel. Okay, what is ROMK? Renal outer medullary potassium channel. That is the second thing. Okay. Third is there is a loss of function in this channel. What we call it as a chloride channel, coded by a gene called Bartin. So basically remember, whenever there is a loss of function, practically these channels becomes useless. Okay, so these are not working. Okay, right. Are you able to follow? Right. So now what is going to happen in this sodium potassium chloride co-transporter? All the substances will be transported across the lumen into the tubular epithelium, right? It will be like this: sodium, potassium, chloride, everything will be going into the epithelial cell, right? Tubular epithelial cell. Now this is not happening. They are getting lost in the urine. Are you able to follow? Number 1. Number 2 is that this number 2 is the ROMK channel, which is again for transport of potassium. Okay, K means that potassium. Okay, this potassium channel is not working. So again this potassium is lost in the urine. Are you able to follow? I will tell you the importance of this chloride channel. The importance of this chloride channel is because it may not be very important in the renal section, but this chloride channel is also expressed in cochlea. Okay. What is the importance of knowing this is because some cases of this Bartter syndrome can be associated with a chloride channel problem in the cochlea also, causing sensorineural hearing loss. Remember, this condition is not seen in all cases of Bartter syndrome. Only in type 4 Bartter syndrome you have that. Now, I don't want to concentrate much on this types of Bartter syndrome, which is not going to be asked for your exams. There are so many types, but at least just remember only this. Type 4 is associated with sensorineural hearing loss. That's enough. You need not know the subtypes of type 1, 2, 3, 4, 5 and all. Not going to be asked in your exam. Just know that type 4 is associated with sensorineural hearing loss. That is enough. Okay, right. So let us see what would be the consequence. There is loss of sodium, potassium, chloride in the urine. Okay, in the urine. Right, number 1. Now what is going to happen is sodium loss will also cause loss of associated water along with it. You all know that. Okay, so this causes dehydration or loss of intravascular volume or decrease in the intravascular volume. All right. Now what does it result in? This would result in stimulation of renin release from the kidney, thereby activating renin-angiotensin aldosterone mechanism. So what is going to happen? Now aldosterone comes into the picture and this is going to act on the collecting ducts. What does it do? It will cause sodium absorption in the collecting duct, but it will also cause potassium secretion, okay, which will be lost in the urine, right? Which will be lost in the urine. Are you able to follow? So there is loss of sodium, potassium and chloride in the urine. This sodium loss would be compensated to an extent by the aldosterone, but potassium and chloride will always be lost in the urine and will be continuously lost in the urine, resulting in hypocalemic, hypochloremic metabolic alkalosis. Is it clear? Right, that is the first consequence which you need to know about. Okay. What is the second problem? The second problem, I'm just going back to the picture. Now, normally when the movement of this sodium, potassium and chloride occurs into the cell, normally it creates a gradient for calcium to be absorbed from the lumen into the blood vessels. Okay. Now, what happens when these channels are not working? There is also loss of gradient for the absorption of calcium. So, this process also will become blocked. So, what is going to happen to calcium? The calcium will get excreted in the urine in large amounts. So, the second consequence is, this was the first consequence. The second consequence is loss of calcium in the urine, okay, leading on to hypercalciuria. That is the second feature. Are you able to follow this? Hypercalciuria. Now, during this process of hypercalciuria, when there is too much of calcium in the tubules and all, it can result in the formation of stones. Okay. So, please remember, stones are noted, okay, due to hypercalciuria. Okay, right. So, these are the important points about Bartter syndrome which you need to know about. Hypokalemic, hypochloremic metabolic alkalosis, number 1. Number 2 is predisposition to develop stones due to hypercalciuria. Number 3, in some cases of Bartter syndrome, you also have sensorineural hearing loss. Okay, and please remember the onset is in infancy. That is about the summary of Bartter syndrome. The next one I am going to discuss about is Gitelman syndrome. Okay, in Gitelman syndrome, please remember that the onset is in the late childhood. Make a note of it. It is not in a young age like Bartter syndrome. It is usually late childhood, say like 8 years, 10 years, or in the adolescent period only. It's not in young children. Okay, that is the first thing I would want you to remember. And here the problem is there is a loss of function of this one. I'll write it as 1. There is a loss of function of this cotransporter. What is that? It is, yes, sodium chloride cotransporter. Okay, right. And there is also a loss of function of number 2 here. What is number 2? It is TRPM6. What is this TRPM6? It is transient receptor potential M6. You can remember M for magnesium. So, this is something which is involved in the absorption of magnesium. Okay, right? And all these process is occurring in the distal convoluted tubule. This is the point to be remembered. Remember, for Bartter syndrome, I told you ascending limb of the loop of Henle. This is distal convoluted tubule. So, what do you think will be the consequence? Okay, normally if this sodium chloride cotransporter is working, okay, this sodium should have absorbed inside and chloride should have absorbed inside. Are you able to follow? But since here it is not working, this will get lost in the urine. Very simple. Second is TRPM6, M for magnesium, I told you. This will result in the absorption of magnesium. Now, when this is not working, again there will be loss of magnesium in the urine. Very simple. These are the manifestations of Gitelman syndrome. So, what is happening? Sodium and chloride is lost in the urine. Again, what is going to happen? When sodium is lost in the urine, you automatically know that what will be the response? There will be decrease in the intravascular volume. So, when there is a decrease in the intravascular volume, what will get activated? Yes, renin-angiotensin-aldosterone system will get activated, and that will result in sodium absorption and potassium excretion, right? So, in this particular condition, again, there is hypokalemia, and already you know that chloride is also lost in the urine. So, again here the problem is hypokalemic, hypochloremic metabolic alkalosis. Okay, right. Okay. What is the other problem? The other problem is that I told you that TRPM6 is not working. So, there is loss of this magnesium in the urine. So, there is hypomagnesemia. This is supposed to be one of the differentiating features in case of Gitelman syndrome. Okay, this Hypomagnesemia I did not mention in Bartter syndrome, right? So that you need to recollect. Okay, right. So these are the features of Gitelman syndrome which you need to remember. Okay. So basically, if I want to put it as a summary, I want you to remember that in both Bartter syndrome, I will just write it. In both Bartter syndrome and Gitelman syndrome, the common feature is that there is hypokalemic, hypochloremic, metabolic alkalosis, right? Okay. The next point I would want you to remember here is there is also normal blood pressure. This is something which you need to remember. Okay, blood pressure usually normal in both these scenarios. Okay, what is the differentiating feature is that in Bartter syndrome, okay, you have hypercalciuria as a differentiating feature. In Gitelman syndrome, you have hypomagnesemia as a differentiating feature. Are you able to follow this? Right. Now, as far as the treatment of the Bartter syndrome and Gitelman syndrome is concerned, it is the correction of electrolyte abnormalities like supplementation of potassium, chloride, and in case of this Gitelman syndrome, there is also hypomagnesemia. So, you have to supplement additionally magnesium also. Now, one distinguishing part in the treatment I would want you to remember is that in Bartter syndrome, it is mentioned that some of the cases have increased levels of prostaglandin, not all over the body, but in the kidney. Okay, right? And what they have found out is that in the treatment, if you give prostaglandin inhibitors like indomethacin, that is found to be effective. This may be one of the potential questions for you in the exam. Okay, in which of the inherited tubular disorders indomethacin has a role in treatment? Answer is Bartter syndrome, right? So those are the differences between Bartter syndrome and Gitelman syndrome. We now look at the last inherited tubular condition, that is Liddle syndrome. Now this is an autosomal dominant disorder. Please remember, Bartter syndrome and Gitelman syndrome are autosomal recessive disorders, but this is an autosomal dominant condition. Okay, it is caused by mutation in genes called SCNN1B and SCNN1G gene. Okay, basically the problem is it is going to result in gain of function. This is the point. Previously I was saying loss of function, right? But this is gain of function mutation. That is the point. Gain of function mutation. What is the problem? These genes are going to code for this channel called as ENAC. What is ENAC? Epithelial sodium channel. What is the normal role of the epithelial sodium channel? Absorption of sodium, and this channel is present in the collecting duct. Are you able to follow? It's in the collecting duct. Now you can remember like this, because of gain of function mutation of this particular channel, what happened is this channel will keep on functioning at a very fast rate. So what happened? It keeps on absorbing sodium. It keeps on absorbing sodium because it is acting too much. Gain of function, right? So what happened? The sodium, once it is absorbed, will enter into the blood, right? And when there is too much sodium in the blood, what do you think will be the problem? The problem is going to be hypertension. Very simple. Are you able to follow this, right? Now what happens is that when there is too much of sodium in the blood, please remember this will cause suppression of aldosterone, right? This will cause suppression of aldosterone, right? So actually in this particular condition, there is low levels of aldosterone. However, you see the features like that of an increased aldosterone. How? In the form of too much of sodium, in the form of hypertension. So that is why this condition is also called as pseudo hyperaldosteronism. Pseudo hyperaldosteronism. Did you get that point? Okay, right. So that is about Liddle syndrome, which you need to know for. It is activating mutations in epithelial sodium channel. The next problem is that whenever there is too much of sodium absorption, you also remember that there is loss of or secretion of potassium. Always remember, one positive charge is absorbed, one positive charge is secreted. You all know that. So this results in the loss of potassium in the urine, thereby causing hypokalemic alkalosis. Are you able to follow this? So this is a condition with hypokalemic alkalosis and hypertension, but low levels of aldosterone. That's why it's called pseudo hyperaldosteronism. What do you think will be the treatment of this condition? You have to some way or other suppress the activity of this over-functioning epithelial sodium channel. So you have to give a blocker of epithelial sodium channel. Does any drug come to your mind which is epithelial sodium channel blocker? Yes, it is amiloride, which is supposed to be the treatment of choice in this particular condition, right? So to sum up, in this inherited tubular disorders, you had a common feature of polyuria and failure to thrive. And from the discussions, you might have very clearly understood that in all the conditions, you have hypokalemic alkalosis. Okay. In Bartter syndrome and Gitelman syndrome, what was the common feature? The blood pressure is normal. That is a point I would want you to remember. Whereas in case of Liddle syndrome, the blood pressure is increased, right? And the distinguishing feature of Bartter syndrome, which we already discussed, was hypercalciuria, and it is associated with stone formation, right? And the distinguishing feature of Gitelman syndrome is hypomagnesemia, right? So this is a summary about the features and the distinguishing points of different inherited tubular disorders. And that concludes our discussion about inherited tubular disorders.